many familiar faces and welcome a new one also. I hope you all are feeling refreshed and ready for the day of inspiring session and meaningful discussion. A special welcome to all the esteemed dignitaries, distinguished speakers, owner of the guests, and of course all the participants. Your presence here today not only add the value but also reflect your commitment to learning, sharing, and creating a better tomorrow. Yesterday we explored some truly transporting ideas and today we are going to take it step further. So let's dive right in the same energy we had yesterday. Once again, good morning everyone. As per the schedule of yesterday, our panel discussion began on time, but due to some unavoidable time constraints, Dr. Suresh K. Sarma sir did not get the opportunity to speak during the session. Dr. Suresh Sarma sir, we are sincerely apologize for this inconvenience and we are truly value your time, presence and your insight you brings. And thank you so much sir for kindly accepting our request to conduct another session at today. Your understanding and the support means a lot to us and we are truly grateful for your gracious presence sir. Once again welcome you sir and thank you sir. To guide this session, I would like to invite Mrs. Sandila Emmanuel ma'am. Please welcome ma'am.
Good morning to all. It's good to see you on the second day and as rightly said by the conveners of this today's program, I'm truly indebted to Dr. Suresh Sharma. Thank you sir for accepting to be here today and indeed we were looking for your expert speech yesterday. So dear audience, the last panelist of yesterday's discussion on accelerating the action for sustainable development goals, we have Dr. Suresh Sharma, who is a very distinguished person with a very rich experience. He is currently the professor cum principal of College of Nursing, All India Institute of Medical Sciences, Jodhpur. He has very long CV. To condense it, it has been very difficult for me, but just to introduce him with a few words for want of time, he has completed his education in Ajmer and he has done his BSc in Rajiv Gandhi University of Health Sciences and MSc Nursing in the branch of Medical Surgical Nursing in PGMR Chandigarh, and he has obtained his doctoral degree from Punjab University Chandigarh. He has been very instrumental in guiding students and has been a very ardent nursing educator come clinical practitioner. He has varied research experiences. He has done personal research at the individual level and collaborative researches, and he has been guiding students for their research work. He has contributed to various textbooks and published various textbooks, and he has a very rich contribution to the scientific body of knowledge with various publications. And he has also attended and organized various workshops and conferences, and truly we are glad that he could make it, and thank you for your understanding sir. And I now request Dr. Suresh Sharma to talk on the community-based approaches, which is very important to tackle or combat infectious diseases. As I mentioned yesterday, all of us are aware what impact the COVID had on the community, and at our own individual levels how we were able to fight this disease, and what more is there to combat this infectious diseases, so that we will be moving towards achieving or accelerating action for the sustainable development goals. Over to you, Dr. Suresh.
Thank you so much, Mr. Emmanuel. My greetings from All India Institute of Medical Sciences, Jodhpur. And at outset, I would like to express my heartfelt thanks to Dr. Siddaram, the Dean and Principal of Charotar University for inviting me and giving me opportunity to speak to this August gathering, and my sincere apology for not being available on extended time yesterday, because I do have a additional responsibility of Chief Nursing Officer in hospital where I control 2,400 nurses. So I had back-to-back meetings after 12 o'clock yesterday. So I could not make it. And I'm grateful that organizers have considered me today morning to speak to beautiful gathering who has traveled to this conference. And my also sincere thanks to the Executive Committee, President, Vice President, Secretary of SOCHNI, who had considered my talk for this conference. Let me share my slides and then begin the talk. I hope you can see my slides.
Yes, sir, it's visible.
So the topic assigned to me is a community-based approach and how this can contribute in combating infectious disease and vaccine gap. This next 30 to 40 minutes will take you through how community can drive the efforts to combat the infectious disease and can bridge the gap of vaccination, primarily the adult vaccination I'm talking here. What are the barriers and what strategies we can impose so that community-based approach can help the system to achieve these two goals? When we talk about community-based approach, how we define the community-based approach, there are two important terms: community ownership in addition to community partnership. And this ownership has to be culturally relevant. So focus of participation is leadership by local residents, and all the interventions which we are tailoring, they are custom fit or the local language fit, so that the acceptance of the people becomes more than any way other we do. For example, we do peer education, we do home visits, we do community mobilization, and so on is a community-based approach to get an understanding what is community-based approach. And we have seen during COVID, as Professor Emmanuel mentioned, that community has contributed largely to control the COVID pandemic. Community has power. How community has a power? They have a vital role to take care for their health, health of the family, health of the neighbors, health of the region, and health of the nation. And there is a investment benefit, because when you employ people from outside, how much people will employ, how much resources you will allocate. But when people take their own responsibility, people take their own family responsibility, you will have the team as everyone, 1.5 billion people who are contributing to that. You can understand the quantum of people who are committed for this particular cause, and the resources, whatever the resources they have allocate for this purpose. And those resources and this manpower become huge. And when the system, that is government, NGOs, healthcare system, and partner with the people, this force become a magnificent force which can turn the big mountains. And this is the time for call for action, that we need to have a community-based approach for meeting out any of the challenge, be it an infectious disease, be it a non-communicable disease, be it an adult vaccine gap, or anything else. When we talk about combating infectious disease through community-based approach, the first and foremost thing is health promotion, disease prevention. And when we have any surgence of disease, then we talk about control, and for which we need to be having preparedness for the people. And we need to understand about infectious disease. Any disease which is caused by pathogenic microorganism, which are potential to be spread by direct contact, or through airborne, or through droplets, or they may be vector-borne. Few examples are like COVID-19, influenza, tuberculosis, HIV/AIDS, and Ebola, and many to name. WHO data has shown high global disease burden. We have a mountains of non-communicable disease, but there are a lot of infectious disease still prevalent in developing countries. countries, in underdeveloped countries, and there is resurge of infectious disease like COVID-19 pandemic or other viral infectious diseases which are not sparing even developed nations. And we have seen during COVID-19 pandemic. Why we are talking about community-based approach today? In my preamble slide, I have mentioned that the pooling of resources from community and giving responsibility for everyone for their own health, that is health promotion, disease prevention and control. We can have a huge manpower, huge resources with us. In addition to the healthcare delivery system which we have. So we will have an extended reach beyond the healthcare, those clinics, PSC, CSAs, hospitals we have. Everyone is health informed, capacity builded within the home to take care about these. And there's an increased trust between healthcare, government and people. And there's a long-term sustainability of this model. And definitely this is cost effective. Government can allocate any resources, can employ any number of manpower as we have seen in developed nations, but still, when pandemics like COVID-19 come, all the resources, any huge manpower can scoop it. But community-based approach can definitely have a difference in cost effectiveness and effectivity. Now, how we can combat infectious disease through community-based approach? There are many approaches, but there are 4 key approaches which I'll be touching up here is that continued disease surveillance, continued health education and capacity building for people, sanitation, hygiene, and 4th is vaccination. So we need to have a real-time data analysis with us. Government has now increased the digital resources to capture the real-time data. For example, we had a mobile lab during COVID pandemic where we were updating our data and we were also updating data about our vaccination status. Similarly, we need to develop culturally sensitive and local fit health messages for our own. And we should deliver them through community trusted stakeholders so that people become capacity builded and the wrong belief system which is prevalent in the people will be shaded off gradually. Similarly, sanitation and hygiene had been talked from the era of Florence Nightingale, and we even talked today about hand washing and improved infrastructure for hand washing and hygiene at school, household, community, everywhere in health system. This will definitely help us to have lesser infectious disease and better vaccination will create a difference. Let us talk a little more about strategies of surveillance and early detection. We have community health workers with us and they monitor and report disease to the local system. But if we sensitize everyone beyond the ASA workers, there are community activists, there are community informers, there are community influencers. Those people, if sensitized, they will be rapidly and soon will communicate the data and we will not have a miss of information. Like there had been talks that what maternal mortality rate we have and infant mortality rate. There is a lot of maternal mortality rate which is happening in the community after the delivery are not being reported to health centers. And what we are reporting may not be true to that. So our surveillance, this is the one example which I'm giving away from infectious disease, but this is one example. There may be other kind of infections which are not being reported truly. Unless it will not be reported truly, the combating strategies which we designed will be ineffective. So I said that reporting system we need to buck up through community involvement, and this will have a rapid, and the ASA workers, the ANMs, the healthcare system creates a rapid response system through the community-based approach. For example, we in the real-time monitoring help the Ebola in Western Africa, and that they could do only through the community-based approach. Otherwise, it would not have been possible. I talked about health education and health promotion. I talked, and I'm reiterating that culturally tailored, culturally sensitive messaging, the local language, which talks about local foods which are available, the local taste which people prefer. In that reference, when you talk, people will easily accept. And when it is being talked about the people to whom they believe to be, true and they have influence on them. Through them, if you deliver, the healthcare system delivers the message through them rather than the healthcare profession which are posted there do it. Probably people will accept it and people will follow it. Local media messages will definitely have influence on them rather than the medias which people are not consuming locally. Community workshops which are focused on hygiene, sanitation, importance of vaccination. This could be through schools, this could be through local mohalla interactions, and this will definitely have an impact. And we have example here that hand washing campaign reduced diarrheal incidence from 30 to 40% in Bihar in one region where the ICMR did this. I talk about vaccine coverage, and we need to have vaccine campaign. We are doing a fantastic, marvelous job in vaccination of children, and in the mission Indradhanush has asked to a level that the success rate has gone beyond 90%, except few pockets. But when we talk about how many of us are taking influenza vaccination? No, we do not. And then we suffer every season change, and we have our own immunity which is being developed. But this is the one example. Similarly, we have a cervical cancer prevention vaccination for the girls. How many of them are taking? And there are n examples. Now vaccination is being even tried for control of other vector-borne diseases like dengue. But how many of we are taking it? There is a vaccine hesitancy prevalent all over the world, including developed nations. Now, India's community campaign-led near total polio vaccination education is a good example that through community involvement, right messaging, true motivation, through trusted local messengers can reduce the vaccine hesitancy. And mobile clinics, which goes to the local area and the people will have easy access, probably will increase adult vaccinations and 100% child vaccination and pregnant women vaccination. This is the one case study I would like to touch upon is HIV/AIDS prevention, and community-based testing and counseling increase the diagnosis and link to the care. Condom distribution promoted safe sex, reduction transmission, and this is being done by the community driven approach. In peer support group, and what was the outcome? Outcome was reduced HIV transmission and improved health. This is the case study I'm talking from Africa. So if we do community-driven approach, a disease like HIV and AIDS could be reduced to 60% in that region, then definitely we can catch hold other infectious disease. Maybe those are vector-borne, or maybe they are viral in nature. Probably we can definitely have a success. But what are the challenges? When we talk about challenges, we have limited resources. How many stakeholders will be having time to participate? Everybody is on job. The labor is going for labor work. The household, the housewives may be busy with their family chores, and the person who is employed somewhere will go to the job. How many people can fully contribute into it? Do the politicians who are free will participate? We have a limited resource. We have limited trained personnel, infrastructure, availability of people, fund, and cultural beliefs are so deeply rooted in us, specifically Indians, and maybe in other countries where I'm not sure. The misinformation and stigma hinders the program acceptance. If we talk about polio, we have eradicated polio, but still there had been few cases in the past. The reason is there are some religions which have deep-rooted belief system that, and this is difficult of all the campaigns, probably their own community based or community-driven approach can break that, and that did in some of the regions where have been tried. Political instability in some of the areas does not allow to take up these programs. Like if I give an example of West Bengal, the central schemes are not being implemented there. So this is a political conflict. I don't call it political instability, but political conflict. And one of the international examples is ongoing on conflict in Syria impacted disease control efforts when we talk about political instability. And there are many other nearby countries which have this problem. Now, how we can measure the success of community-driven approach or community participating approach, disease incidence rates, vaccine coverage, health outcomes, and community engagement by measuring the participation, level of satisfaction with programs, will tell us how this participation has benefited us. And we should drive from small to the larger initiatives. Let me also touch upon the vaccination gap. And I was recently in Sweden, invited in Sweden, and their health agency is talking about 4 important health priorities, and one of the health priorities is the vaccination gap. And we had a brainstorming session where I also got an opportunity to speak for 10 minutes, how we can combat this vaccination gap primarily for adults, and specifically in developed countries where health literacy is less. And the problem persists everywhere. CDC data also says the vaccine rate is vary by ethnicity, locations, income status. If you give an example of MMR national rate in 2022 is 93.1% in our country. And if you talk about herd immunity, there is 90%, 95% measles vaccination. So if we say it is not 100%, and this is we are talking about childhood vaccination. Adult, if you talk, the data is very, very low. Now, what are the factors which are contributing to vaccine resistance? The first and foremost is misinformation and distrust. False claim by healthcare companies, and then the load of adverse effect fuel the hesitancy more. So the access barriers are like there's no transportation, the cost of vaccination is very high, the appointment of availability of the resources which are there, they are not there available. Cultural and language barriers are there. Communication gap is something which creates a major problem. Like if I would have been communicated yesterday in the morning that the schedules may be delayed, I would have preponed my meetings in the morning and I would have been available for this talk yesterday. So communication gap could happen by culture, language, busy schedules. Probably at your end it has happened by busy schedules. But for vaccine, if you talk, the cultural and language barriers are major contributing factors. Now, what is the impact of low vaccination rate? Either in the child vaccination or adult vaccination is disease breakouts, high cost of the treatment when the disease happens, and vulnerable population suffers more, specifically the older people, the young child, the immune-compromised people, they are vulnerable. And marginalized groups who are having less money, and when they are affected, they don't have money to pay. And we are lucky that we are in India and we have Ayushman Bharat Yojana, where the government pay for you when you take this treatment in government hospitals. But this is not facility in every country, even some of the neighboring countries where the government does not have that money. But what are the methods to address vaccination gap? The 3 most important, which I would like to highlight, is mobile clinics, which has these projects has been done in many countries and have been very successful. You take a mobile clinic, go to one mohalla, be there and vaccinate those people. I'll tell you that it will happen. And involve religious organizations, involve local leaders, local influencers. They'll bring those people and get vaccinated. Door-to-door campaign, personalized outreach, education, combat misinformation and vaccination. Incentives also benefit a lot. If you tell the people that you bring a person, then an incentive will be given to you. And this cash-based incentive, like in institutional delivery we have achieved in our country, where we pay X amount to the ASA worker or any healthcare professional, even in trained dies, if they bring a woman for institutional delivery, they are paid X amount, and see the status today. We are very close to 100% institutional delivery if we talk about country, except bearing few pockets in Uttarakhand, Uttar Pradesh, Assam. The rest, we have in most of the states, nearly 97, 98, 99% deliveries are happening in hospitals. So incentives also can really make a difference how vaccination gap can be reduced. When we talk about community-based strategies, I also want to touch upon a multi-pronged approach. In addition to these 3 approaches which I have taught, mobile-based, clinics, the incentives, and door-to-door campaign. The two more things I wanted to talk is tailored intervention. Those programs which you are designed for that particular community, that particular region, and trusted partnership from community leaders, organizations, NGOs, churches, temples, and mosques involved in. They are the influencers. They are the community influencers. They can mobilize. The other important thing for vaccine hesitancy is build a trust through community engagement. Listening sessions. Listen to the people, what they think. Openly listen to them. Then give them accurate information so that the myths can be eliminated and facts can be influenced. Trusted messengers to be used. Doctors, nurses, leaders. Build a credibility that what information you are giving is 100% true. We do the ethical messaging. Now, how you can improve the access of vaccination services is, as I said, mobile clinics, and have a healthcare facilities on permanent locations where people can travel very easily, and easy scheduling. Like we keep the health facilities off on Saturdays and Sundays, and most of the people have holidays on Saturdays and Sundays. So why don't you keep holiday on other day for healthcare professionals and keep your health clinics open on Saturday and Sunday when people can travel to? In one case study, the Black Coalition Against COVID in US, and they found that the Black population is more infected and having more deaths. So what they did, they partnered with Black churches. They launched mobile clinics in education for COVID vaccination for Black people, and targeted misinformed campaign for people, and involved the priests, the local church priests, and suddenly within the 1 month period, 20% increase in vaccination rates. So this is the one case study which tells us that how community-led participation here, that is translated material into the local English, culturally sensitive message, and community health worker are bridging the cultural gap and facilitate the trust we contribute into how community can participate in controlling infectious disease and leading to vaccination, bridging the vaccination gap. There is a call for action. We need to invest on community-led solutions. We are still ignoring the gold mine which is lying with us, who are the community partners into improving our health. So what we need to do, we need to fund community-based programs. The people who are contributing, we should give them incentives, empower these organizations which are contributing. Maybe churches, maybe religious people, maybe the local leaders, maybe the people who are just sitting free in the villages, and create equity to all the sections of the community for their involvement. The upper level, the middle level, and even the lower level. Even the women empowerment groups. Barriers to effective community participation, as I said, that there are resource constraints, there's a limited time, limited fund, limited facilities, limited staff, there's misinformation, mistrust, there's a gap of link between healthcare professional, healthcare system, and local people. Cultural and linguistic barriers and logistic challenges like difficulty in reaching to marginalized and remote located communities like hilly region or difficult terrains. But there's a reason to success, and that can happen through strong leadership. And in a healthcare system, we need to have a strong leader who has a vision to involve the community participation, trust and rapport building with people, data-driven action and multi-sectoral collaboration, engaging government, NGOs, private sector, and every stakeholder from community. Results and outcome of this community participation on infectious disease will be case reduction, treatment success, and strengthened resilience of communities, and which has been shown from two examples here: 30% drop in malaria intervention zone in one of the pocket in India, and treatment success of 20% higher in tuberculosis completion rate in one of the region West Bengal. So this shows that how community participation can bring the influence on controlling and combating infectious disease and bridging the access gap. Similarly, for vaccine gap, there is a reduced childhood illness because of vaccination. There is 90% measles vaccination and 0% polio cases has happened through community participation. contribution to the healthcare sector by community participation is we need to have expertise and training for building local skills. Because if you are engaging the people who are themselves disbelief, cannot contribute. But we need to train them, we need to do the skill capacity building for them, and then they do it in their local language and local culture, driven interventions. We need to have access of medicine and vaccines. We need to have infrastructure training so that the data can be captured and there could be linkage between higher centers and these local contributors. And supporting health workers who have a supervision and mentorship for these community participants and stakeholders. To conclude, the future of community-based approach is scale successful models of involving community. And I urge here the postgraduate students and doctoral students and faculty, young faculty sitting here, develop some community-based approach models. And these models try and test into some of the regions and then show us a data of success. And then let us replicate into whole state and whole country about that and talk about that. Maybe palliative care model we have a Kerala model of palliative care, which is based on community participation. And cancer is on rise. So I'm giving you some thoughts here for a bigger project where ICM are concerned. We have a CIPLA funded project where we are doing community participation in palliative care. We discharge patients from our hospital. Before discharging, we train the family member, and this family member who have been trained and caring for his patient who's having cancer, which is under palliative treatment. Ultimately, after this, we lose this patient over the time. This is a trained person, and we whenever in that region any patient is, we are discharging, we link with them. So this person becomes a further monitoring and supporting and training that family, and this is how we are building. And if somebody is having free time, they also can contribute into serving the home-based care, either the paid or unpaid. Engaging all the stakeholders, reaching global health goals by community participation solutions will have a lasting impact and sustainable model. That's all from my side. Thank you so much for your patience hearing. And if you have any questions, I am very, very happy to answer. And once again, thank you to Chair and thank you for this opportunity.
Thank you, Dr. Suresh. That was a wonderful presentation with so much of real-life examples. It was truly informative. Are there any questions from the audience? No? Okay.
I can see my colleague Tomer Rodney from Johns Hopkins.
Yes.
Hi, Tomer.
Yes. Dr.
Tomer, in October, I was at Washington, D.C. for receiving my FAN. And I was thinking I'll see you there, but I think probably because of busy schedule you could not.
No, I was busy cheering you on in the crowd. I was there.
Oh, you were there?
Yes, I was.
Oh,
and congratulations again.
Thank you so much. Thank you, Tomer. Thank you.
Yes.
Yes, Dr. Suresh, there are no questions from the audience, but I would like to make a comment from my end. In mobilizing the community, we in our department are able to tap on the women's self-help group as one of the approaches that we have and that has worked successfully. So I think women are very good catalysts for promoting the interventions and bridging certain gaps. That is my take on that. So I just wanted to add on to what you have said.
Absolutely agree, ma'am. Thank you, Professor Emmanuel. The CMC Vellore, and specifically the College of Nursing, is well known for women self-help groups in a community mobilization of resources. And I would have given this one of the example. Thank you so much for reminding and telling us about it. And this we all should learn and do something similar in our reasons. Thank you so much.
Thank you very much for having been with us and sharing your insightful thoughts. Thank you. You can stay on if time permits you. We are moving to the next panelist, Dr. Tamar.
Thank you so much, ma'am. I'll listen, Tamar, and then I will ask for excuse. Thank you. Bye-bye. All the best, Tamar.
Thank you, sir, for being there. So, we have Dr. Tamar Rodney, who is currently the assistant professor at the Johns Hopkins University, Maryland, USA. Thank you, Tamar, for joining us in spite of the difference in the time zone. We are very happy to have you with us this morning here. And just a brief introduction about Tamar. Tamar has been graduating from Dickinson State University with a bachelor's degree, and later she has done her master's degree in the psychiatric nursing from University of Vermont, and later she has obtained her Doctor of Philosophy from the Johns Hopkins University. And she has a very rich experience as well in research and education. Her top skills are with clinical research and healthcare and nursing. She has been awarded with the Geneva Foundation Healthcare. She has been a scholar and she has been awarded the 2017 NLN Foundation Scholarship. We are very proud of you, Dr. Tamar. And Dr. Tamar has also a very rich experience of ongoing global networking and professional advancement. She has been very instrumental in curriculum development, enhancement, and program evaluation. And she is a person who fosters research and has a lot of educational initiatives and very instrumental in disseminating innovation in doctoral nursing education. We are very glad to have you with us, Dr. Tamar, and dear delegates, as we are discussing and focusing on the Sustainable Development Goals. Mental health is also one of the aspects that is given focus in our SDG 3. And you know, since COVID, mental health issues have been on the rise, and it is a real concern. The statistics as available says that the mental health concerns are ever increasing, and there is a lot of stigma attached even with mental health. So here we have Dr. Tamar talking to us about mental health in communities, addressing stigma and improving access to care. Over to you, Tamar.
Thank you so much, Madam, and good morning to my colleagues. It's an honor to share with you. If I could just get a quick check, I can no longer see my screen, but if you could just let me know if you can see my presentation screen, that would be wonderful.
Yes, we are able to see that.
Great. Thank you, and thank you again for the invitation. It's sometimes what hinders us collaborating is the time zone, but I think an effort, especially in spaces like this, becomes an incredible opportunity to further the work of nurses and nursing as well as healthcare. And so thank you for the wonderful introduction and the opportunity to share with you. So I'm going to focus my remarks this morning on the innovative teaching strategy in mental health nursing and how we might be able to advance the SDGs by 2030. Part of my role, apart from research, is in education for mental health, and I'll try to focus our points to 4 main points. First, to look at the SDGs, primarily goals 3 and 10, and looking at how we can leverage innovative teaching to achieve not just global health, but global health equity, and to specifically explore some what I call emerging trends in education, and looking at the specific challenges that we might need to overcome while going forward. And then how might we prepare our nurses for complex mental health challenges? And I like to start with making it make sense. And so why does it matter? Why does mental health matter? Why does education matter? And that is primarily because it's too many persons. So we know by age 75, approximately half of the population worldwide is expected to develop at least one or more of the main 30 mental health disorders. And to date, that reflects in about 1 in every 8 individuals. And if we put that into a room that we're sitting at, every 8th person we could think has the potential to have a mental health disorder. That I think is worth something looking at. And this number is about 970 million individuals, which is another 13% of the global population. So it's significant, isn't lost on us. And so we know it affects individuals, just about half. So it's not necessarily gender specific, although some disorders are worse than others. It really shouldn't matter what mental health disorder it is. What should matter is the impact it has on our lives. However, if we wanted to put it into specific disorders, the disorders that are of most concern are primarily anxiety disorders. And this includes panic disorders, social anxiety disorders, social phobias, and separation anxiety disorders, which very often affects children. And so we see at least 301 million individuals affected by anxiety disorders. This information is usually flipped because I think most individuals we ask about what is the most prevalent mental health disorder, frequently the answer is depressive disorders. Yes, it's still a significant number, and that comes in at $279 million. And so major depressive disorder is considered a serious mental health illness. But this also extends to persistent depressive disorders, perinatal depression, seasonal affective disorders, as well as the more severe type with individuals with psychosis. And so the list is extensive. We have other what are considered serious mental health disorders, bipolar disorder, schizophrenia, eating disorders. But this list is by no means comprehensive. So we know it affects a lot of individuals. The question we get to ask ourselves is, what is the role of mental health nursing in global health? I would like to think about this. And so we know mental illness is rising globally. We know one of the primary difficulties is that access to care remains unequal. And this is unequal across the globe. And so a part of the solution has to be mental health nurses, which will be necessary not just for care, but for also equity and for the way we change the delivery of care. I think a part of the solution has to start with education and training. And why education and training is that if we start here, we can start to dismantle the disparities in mental health treatment. We can also look at care across different cultures and countries, as well as integrating mental health care in primary care as a specialty care. So mental health workers globally is about 9 individuals per 100,000. But we know that what influences this in an extreme variation is that countries considered low income versus countries considered high income have worse access to care in low income countries. So not just education, but education is where we start. But global mental health care should involve research and practice primarily to improve mental health for all people. And it should always take into consideration the disparities in mental health treatment and the care across different cultures. And so while we know the interest in global mental health has grown within curriculum across training programs, it doesn't cover enough. And I still think that there's lots we can do to get here. So our guiding principle for this evening is what I call goal setting. And so in the UN adopted what we now know as SDGs, recognizing the promotion of mental health and well-being, and the prevention and treatment of substance use as a global health priority. It is one of 17 goals. And so in 2015, September 2015, they recognized at that meeting that the new global sustainable goals should specifically call out mental health as one of its priorities. So it is good to have. I, however, think it is still buried. It is buried as goal 3, and the charge is that we should ensure that there's healthy lives and promotion of well-being for all ages, and specifically goal 3.4, to reduce 1/3 premature mortality from non-communicable disease through prevention and treatment and promotion of mental health well-being. So if we're being extremely picky, we really do have to dig deep to find mental health as a priority. However, it does exist, and I'm very grateful that it was prioritized on the global scale as one of the goals that we could get to by 2030. We only have 6 years left, but I do think 6 years is a lot of time to do a lot of good work. So how about we begin by looking at where we can start within the education realm to get to this goal, and what might we change? There are different pathways to educating individuals to be specialized in delivering mental health care. And I'll share what the US model looks like, which I still think is way too complex, but it's a helpful roadmap. And so most nurses will start at what is a bachelor's degree in nursing. Some might progress to a master's of science as a specialization, and this can lead to an advanced practice degree. There's also the option of a doctorate of nursing practice, which is a doctorate of nursing practice, or DNP, and this can also lead to a specialized advanced practice registered nurse role, or APRN. Other registered mental health nurses can go to practice across the lifespan. But one of the things I think about this is that it feels like it should be a linear process, but not all individuals will follow this path, and because this is a lifetime of a career if an individual chooses to specialize in mental health. So I think part of the things that we need to do is to change this roadmap. How do we get to a specialization in mental health as a part of our nursing curriculum to ensure that it is, as a specialty as it's currently listed, is accessible for more individuals? And the first part of this is to ensure that mental health is integrated at the Bachelor's of Science level. And so while it might not be advanced practice as we know it, we should be able to deliver mental health. The other part is ensuring that this training is delivered across the lifespan as a specialty and much earlier. So from this roadmap, I think it still remains incredibly complex, but it also gives us an opportunity to introduce, 1, mental health training earlier as a specialty, and 2, to ensure that when it's introduced, it is introduced across the lifespan, because as in the previous slide that we see, that it does affect individuals almost equally and across the lifespan as well. And if we stay on this roadmap, what we think about is, if we do have a mental health nurse, what is the scope of practice that they get to do? And so this should be everywhere. And it should be inpatient, outpatient, community. It should be individuals trained to also carry on that torch of education. And this education, it shouldn't just be in the classroom as we know it. It should be options for teaching. It should be options for clinical teaching. It should also be an option for a preceptor. And this is one of the things that I like to stress, or having difficulties with finding a mentor and a preceptor while I was training. One of the promises I made to myself is, if I had the chance to be a preceptor to someone else, or to share what I know with someone else, this would be a gift to encourage someone else to follow in mental health footsteps. So to summarize from here is, 1, changing the model of mental health nursing, and 2, to expand their scope of practice. And the last part is defining, what does a mental health nurse advanced practice or bachelor's prepared nurse do? And so it should be a part of the nursing process. Some of the specialty is to establish a therapeutic relationship, education in patients and families, diagnosing mental health order where appropriate, and also be a part of the treatment team, which should include medication, psychotherapy, and managing both acute and chronic illnesses. So the Psych NP role should be comprehensive. It should be explaining. It should be also at the full scope of practice, meaning they assess, they diagnose, and they also treat. So the limits that are previously introduced as to where we get this education should be removed as a part of getting to the goal. So for the education realm is removing those barriers earlier. The treatment modalities would be the secondary piece of where we try to expand this care. And so the opportunity for independent practice, while it's not practical across the globe, we do have templates where this does work. We do have advanced practice mental health nurse practitioners who can carry out independent practice with education. We should also expand the idea of collaborative practice. The specialty of mental health, we know, allows for specialty care, but the reality of how the disease process takes place, we infrequently see a singular disease. What we do see is comorbidities. And if we're able to provide both sets of care, the head and the heart, at the same time, we should be able to do that. And in doing this treatment, we should be doing it for everyone as a preventative treatment, not just when the illness occurs. And again, always including not just medication management, but also psychotherapy to have holistic care. So those are ways that we can expand the current models of how mental health training is given, expanding the scope of practice, and ensuring that treatment modalities is comprehensive and collaborative. Now I want to move into two different modes of how education is delivered. And so we think of the traditional classroom with desks and chairs, and what I would want us to think about is this model limits the amount of students we can hold in a physical building. And so the concept of virtual education should be something that we consider. And what this does is we have a physical building, most schools of nursing, but expanding this to the virtual space, meaning that we have a block radius offering world-class education. We could put that in the virtual space. So similar to delivering a lecture or a conference online, information can also be recorded for full course content virtually, and we do have successful examples of this. So I call this the reinforcement strategy has to be, if we're educating individuals, we also need a proof of concept that it is happening. So it's not completely virtual, where we never see individuals in person. This can be paired with what we call intensive immersion processes. So we have specific times across maybe a 3-year program that we do ask those individuals to join us for that in-person component for testing of skills as a part of that process. So let's talk about what are some of the benefits of what essentially is virtual education, but distance learning. So if we engage training of our mental health nurse practitioners or clinicians in a distance learning, one of the things that we do is allow access for individuals who might be remote or areas that are previously underserved. We also reduce the barriers of transportation to daily school or the cost of maybe living in a close proximity, so those individuals can access learning from home, stay at home except for their immersive component. It also allows us to promote global teamwork and equity, which means that we can have our course delivered from individuals who are not just in the physical building, but it could be partners from different schools. And this specifically aligns with SDG 4 and SDG 17 about how we collaborate with distance learning. So distance education really breaks down any geographic and financial barriers, and it also enables cross-border learning, and in this process encourages not just collaborative, but a culturally diverse mental health workforce. One of the things I find that even in just the US is that individuals in different states think and practice very differently. And in the virtual space, just getting to share that broadens their horizon. So imagine having a classroom that is really a global classroom where we learn together virtually, and then we can come together for limited time to again reinforce some of those skills. And so this coming together to reinforce the skills is what we consider the immersive clinical experiences. And these are where our students are placed in diverse real-world settings, whether locally or abroad. And in that space, it promotes first-hand understanding of what are the social and structural determinants of health and their impact on mental wellness. So it might be a weak model, and we would want to design a model that works for the school that we're in. But it could be serving in global communities. It could be practicing skills. It could be doing interview skills. The way we have designed, as the School of Nursing at Johns Hopkins, we do have a version of this in a 3-year concept, where we have students coming in for 6 different immersive clinical experiences. 3 are done virtually and 3 are done in person. But what it does is reinforces the skills that they've learned in a didactic component and expands that to how they do it in their clinical practice and how they get to reinforce that in front of their peers and their faculty. And so those are 2 pieces that I think could, not an automatic expansion, it would need some very thoughtful ways of doing this, but at least it would expand the classroom into a global classroom outside of a physical setting, and hereby reducing some of the financial constraints. The next 3 components I'm going to talk about is the actual education process. What are we doing to expand or to get there faster? How can we get to 2030 by employing different skills? And these 3 tools I think we should consider are: 1, the use of virtual reality; 2, using simulation as a part of our training; and 3, the use of standardized patients. So let's first talk about virtual reality in education. So virtual reality, yes, it comes with an expense, and this would need to be planned out in any program, but it really simulates lived experiences. So it might be as simple as utilizing a headphone to mimic hearing voices, or simulating a panic attack, or allowing the individual to enhance their empathy and insight among students in a safe space. What it does, it allows future nurses and nurse practitioners to respond compassionately and effectively within a safe setting. So using aids, we're training our nurses to do so in a safe space, and this can be repeated. What I also find is that if students are able to experience this before they go into formal clinical training, it makes them more confident because they've seen a version of this before. And where it directly aligns is that it supports our sustainable development goals by addressing enhancing diversity readiness, because we're able to expose students to a myriad of cases. Some of them they may never see in reality, but if they do, they're able to address it because they have seen a version of it before. And I think probably the most powerful part of this is that it can be repeated. We can replay the scenario for that individual until they're comfortable to move on from that, which you don't get in the real world setting. Next is the use of not just simulation, but I would want to emphasize high fidelity simulation. And so this concept offers realistic mental health emergencies, so from anything from suicidal ideation to manic episodes, and it helps students to build their confidence in decision making as well as a safe environment. Excuse me, I'm having a sneeze about to attack me. So again, we're simulating experiences again that our students may not see right away, or we don't want them to see because we don't get to redo suicidal ideation. A manic episode is sometimes very scary for mental health, and you don't get to have a redo. And with simulation, that's precisely what we're getting to do, to have it as realistic as possible, but frequently use what might be emergencies and helping students to build their confidence in addressing this. And third is utilizing standardized patients. Now, this does take some training, and this is really having a bank of actors really to allow for repeated but structured and personalized feedback to our students. So when we engage with standardized patients, two of the powerful things is that students know that although it is simulated and these are actors, that those actors can give them feedback that your real patient might not be able to. And this component, I think, it's crucial for mastering patient communication. It's a strategy that also helps us to develop culturally responsive care, and it also reduces disparities. So it's a scenario where we get to build and practice with our SPs to improve diagnostic accuracy and communication. It also allows for all the students in the room to have access to this kind of training. So it's equitable training for all to build cultural competency. And it's again another safe learning environment. I can say by observing it, our students sometimes get immersed and they're not quite sure if it's real or if it's not real. And so because our actors are so good, they portray it in a very real world-like setting. But what happens afterwards is that debriefing with our students to give them feedback on how they can improve or what they could do, which you don't get in the real world setting. So these are some strategies that I would like to propose. However, I want to emphasize that some of them are requiring a financial, some structural, most of them planning, but we shouldn't be attempting these alone. In any individual case, what we have to understand is that these strategies are helping to develop programs of nursing, but mental health nurses, well, not just caregivers. You're asking us to develop leaders and innovators capable of implementing change across systems. And so utilizing strategies like this, you are going to get the best version of your nurses. And so looking to international organizations or partnership that we're helping to solve just a tiny part of that puzzle. And so as schools of nursing, as educators, as clinicians, we have to understand that there are other partners like the UN, like the WHO, who play central roles in developing global mental health and health policy. And there should be no hesitation to reach out to these individuals, to share what we're doing, to meet these goals and asking for help. What are some of the resources or structures or maybe technology they can share to help us implement some of these strategies? And so this should expand to any of our partners that we think might be helping in this, because remember that the SDGs are global. And an extension of this is that there are foundations that are just as concerned as School of Nursing, and as professionals about the concern for mental health worldwide. And so that is why we see that buried but late inclusion in the SDGs, but it still remains important worldwide. So what I'm presenting to you is what is, I might say, the easier way of doing things, but there are multiple factors to still be considered. We still know that cultural competence in mental health remains an issue. We still know that service delivery in limited resource setting, rural setting, underserved setting is still an issue. We also know that there are higher rates in certain geographic contexts. And we know there are barriers to different health systems and policies. So considering all of this, it is not necessarily easy, but we can identify these barriers in delivering culturally responsive mental health care. We know that we can at least start to break down some of these barriers. Recognizing what we know and what we don't know and being open to learning as much as we can. And in doing so, we are starting to dismantle some of these barriers that for decades have not been touched. I want us to pull us back to where we started. And where we started is the why it matters. And it's the 970 million individuals. So when we face these barriers, we want to think
Dr.
about the 13% of the global population that
Tamar?
we will be able to impact when we get to dismantle some of these barriers. and shoot for some of these, what I think are innovative strategies to essentially get more mental health workers created through innovative education design, innovative curriculum delivery, and innovative ways of practicing to start to dismantle this, to provide the care for the 970 million individuals who are living with mental health disorders. And unfortunately, yes.
May I request you to complete your presentation in another couple of minutes, please?
Yes, I only have 2 slides left.
Thank you, thank you.
Of course. And good timing. Now, the last point is really who we try to inspire. Yes, we're inspiring our current nurses, but where we want to think about is non-traditional aspects of marketing to individuals to change the public view about who should be pursuing nurses. So I leave you with this quote that our jobs as educators and mentors is not just to teach, but also to inspire the next generation of nurse practitioners and nurses to lead with compassion, to think critically, and to advocate for changes in healthcare. And we do this in 3 different ways: to have innovative education, using new strategies globally, and to empower nurses as our sustainable development goal change agents. So I leave my email address with you if there's any follow-up questions after. But I'd be happy to take any questions if we have any additional time for questions now.
Thank you very much for this elaborate presentation and giving a lot of your experience added to this. Dear audience, do you have any questions addressed to Tamar? All of you seem to be mentally healthy. Can I take it that way? But statistics is different. Yes, there's one hand up there. Can you please give the mic?
Thank you, ma'am. Good morning, Dr. Tamar. We are very glad to hear from you, and your lecture on teaching innovation is being appreciated. So we discussed the point that access to care is unequal. So for that, my question is, in what aspects the care is unequal for the access, and what are the areas that we lack in, and how can we bridge the gap of this inequality, or how, as a working professionals, how can we improvise our outreach services for the community population?
I'm going to ask if you could just repeat the question for me, or dearest moderator.
Yes, please.
I wasn't able to hear very clearly.
Okay, I may repeat that we discussed the point that access to care is unequal. So I may ask that in what aspects that the care is unequal, and what are the areas that we lack in, and how can we bridge this gap of inequality, or how do we improvise our outreach services as working professionals in the community population?
Thank you. I think I got it. You're talking about the inequalities for access to care.
Yes.
And that's a great question, because it's not something that we're going to necessarily fix overnight. But I do think I always hesitate to bring up about COVID, but COVID had taught us so much about how we still had to deliver care, and one of the primary ways is again virtually. And so telemental health has been amazing. With that, I do think there are still barriers, because it does mean that the person has to have access to good internet service as well as a safe space to do this. And so while it's not the solution to start bridging access to care and the inequalities there, it is a part of the solution to start delivering that. Because traditionally, mental health and telehealth doesn't quite go together. It usually seems that we're in a secret back room conducting mental health care. But I do think we should really emphasize how can we deliver care, not just video, but also voice. So it could be reaching mental health care by a hotline. It could be still having our standalone physical buildings, but we do want to emphasize virtual care as a part of traditional care options. It shouldn't be seen as different. It should be a part of how we deliver care. And again, it's only a part of the solution, because we need a lot more strategic ways to start to break down some of these inequalities of care delivery.
Thank you. Thank you, Tamar. In addition to what Tamar has said in response to the question raised by the delegate, I would like to say that even during the times of COVID, we have, as Dr. Suresh mentioned, we have an extensive community outreach program. And during COVID, we really had to get the permission from the local authorities, district authorities, during the lockdown times. We did get permission. We were able to make quick home visits and dispense the medicines at doorstep for those who were really down with mental health. In fact, if we would not have intervened, probably there could have been mental health crisis even among these patients. So community outreach is another community-based approach that we could follow, and with so much being said by Dr. Tamar, this is an area where we can really strengthen and do the capacity building for the budding nurses as well as others, so that we could help our population, whoever is within our reach. So thank you, Tamar. Are there any other questions? If not, I would like to take this opportunity to thank the two panelists who were with us, and it really enriched to complete the discussions of this panel. And sustainability is not something that you need to wait for to do good. You can start it today, and you can see that as expected or as spelled out in the goals, we should be able to achieve the targets by 2030. So once again, as a moderator, I would like to thank the panelists and the delegates for being part of this discussion, and let us unitedly take this action and accelerate the action towards achieving the sustainable development goals. Thank you.
Thank you so much, Dr. Suresh Sharma sir and Dr. Tamar Rodney ma'am, for your outstanding contributions today. Dr. Sharma, your session was incredibly insightful and deeply enriching. We are truly grateful for your flexibility and for graciously agreeing to speak again despite the earlier scheduling challenges. Your expertise has added great value to our event. Dr. Rodney ma'am, we sincerely appreciate your patience and the time you've taken to share your knowledge with us. Your thoughtful perspectives and engaging delivery have left a lasting impression on all of us. On behalf of the organizing committee and all participants, I extend your heartfelt gratitude to both of you. Your willingness to adapt, your professionalism, and the depth of your insights have truly elevated the quality of this program. We hope to have the privilege of learning from you again in the future. Thank you once again. Thank you, Mrs. Chandela Emmanuel ma'am, for your graceful and thoughtful moderation to this rich discussion.
Thank you.
Bye-bye.